Here's something most people over 60 never hear from their doctor. Blood pressure targets have quietly shifted in recent years, and depending on your age within that over 60 category, the number your physician is currently chasing might actually be working against you. Too high is dangerous. Everyone knows that part. But too low carries its own serious risks for older adults, and those risks almost never get the attention they deserve. A landmark study published in the New England Journal of Medicine confirmed that aggressive blood pressure, lowering in seniors over 75, significantly increased rates of kidney injury, dangerous pressure drops upon standing, and falls. The kind of falls that send people to the hospital and permanently change their daily lives. So, what is the right number for someone your age? That's exactly what we're answering today, and I promise you'll have a clear, specific answer within the next few minutes. Not a vague range, but actual targets tied to your age and your health situation. I'm Dr. Sarah Mitchell, and this confusion over blood pressure targets is precisely why I put together my guide, the Blood Pressure Protocol. It includes a complete morning check system with printable tracking sheets so you can finally measure and interpret your own numbers at home with confidence, not guesswork. You'll find the link in the description below. If you want real, research-backed answers designed specifically for people over 60, subscribe to this channel so you never miss an episode. Now let's get into exactly what your blood pressure should look like at your age. The short answer is this. For adults between 60 and 79 years old who are in reasonably good health, current evidence supports a blood pressure target below 130 over 80. That means your systolic number, the top number, should be under 130, and your diastolic, the bottom number, should be under 80. For adults over 80, however, that target shifts meaningfully. Research now supports a slightly higher acceptable range. A systolic between 130 and a 50 is considered appropriate, especially for those who are frail, have a history of falls, or are managing several medications at once. Give me the next few minutes to explain why that difference exists, because understanding the reason behind these numbers is what will make this information actually useful to you. Your blood vessels become progressively stiffer as you age. That stiffness is a physiological fact, and it changes everything about how your cardiovascular system behaves. When you were younger, your vessels had elasticity. They could absorb the force of each heartbeat and maintain steady, consistent pressure throughout the day. As that elasticity decreases, your pressure becomes more volatile. It swings more dramatically. It can be elevated in the morning and then drop suddenly when you stand up quickly or walk across a room. That sudden drop, when you rise from a seated or lying position, is called orthostatic hypotension. And in seniors, it is one of the primary causes of dizziness, fainting, and falls. Here's why this matters so much. If your physician is targeting a systolic pressure below 120, which some doctors still do based on influential older guidelines, and your body is already prone to these kinds of pressure drops throughout the day, you may be at real risk every single time you rise from a chair or make your way to the bathroom at night. That is not fear-mongering. That is backed by clinical data from multiple large-scale trials. Comment below and tell me, have you ever felt dizzy or lightheaded after standing up quickly? This is far more common than most people realize, and it's directly connected to what we're discussing today. Now, let me walk you through the research so you understand exactly where these recommendations come from. The SPRINT trial, the Systolic Blood Pressure Intervention Trial, was published in the New England Journal of Medicine in 2015 and sent significant waves through the medical community. It followed more than 9,000 adults with elevated cardiovascular risk and found that patients whose systolic pressure was reduced below 120 had a 25% lower rate of heart attacks and cardiovascular events compared to those kept below 140. Impressive numbers. And those results influenced a wave of aggressive blood pressure treatment across the country. But here's what concerned many cardiologists when they looked more carefully at that data. The SPRINT trial excluded people with diabetes, those who had previously experienced a stroke, and anyone who had significant kidney disease at baseline. When subsequent researchers tried to apply those same aggressive targets to a more realistic cross-section of older adults, including frailer patients and those managing multiple health conditions, the risks became far more visible. Falls increased. Kidney function declined. Dangerous fainting episodes emerged. These were real, documented outcomes tied directly to blood pressure being pushed too low in patients who were not the same population the original trial studied. A separate major investigation, the STEP trial, published in the New England Journal of Medicine in 2021, followed more than 8,500 adults between the ages of 60 and 80 and found that keeping systolic pressure between 110 and 130 reduced major cardiovascular events by 26% compared to a group kept between 130 and 150. This added meaningful weight to the case for tighter control. But once again, these were relatively healthy adults in the 60 to 80 range, not seniors managing 5 medications, not patients with documented frailty. The medical community has spent nearly a decade wrestling with this tension. How do you aggressively protect younger, healthier seniors from heart attacks and stroke, while also protecting older and frailer patients from the very real dangers of falling, fainting, and kidney deterioration that come when blood pressure is pushed below a safe floor? The answer that has emerged from guidelines updated in 2021 and beyond is nuanced but clear. If you are between 60 and 79 years old, you are not on dialysis, you don't have advanced kidney disease, and you are not considered frail by your physician's assessment, the current target is below 130 over 80. Your doctor should be aiming there, and so should you. If you are 80 or older, the guidance from the European Society of Cardiology, supported by data from the HIVET trial, which specifically studied patients over 80, is a systolic target between 130 and 150. The HIVET trial demonstrated that treating elevated blood pressure in people over 80 reduced stroke risk by 30% and overall mortality by 21%. But the target in that trial was below 150 systolic, not below 120. That distinction is critical and gets lost constantly in online health discussions. Let me tell you about Harold. He was 76 years old when his doctor, citing the SPRINT trial findings, adjusted his medications to push his systolic below 120. On paper, his numbers looked excellent. 117 over 71. Perfectly controlled by any metric. But Harold started feeling foggy in the afternoons. He had 2 near falls in the span of a month, both times while getting up from his recliner. His daughter finally brought him back in and specifically requested a standing blood pressure test. Sitting, Harold's pressure was 119 over 70. Standing after 2 minutes, it had dropped to 94 over 58. His body couldn't compensate fast enough. His physician reduced his medication slightly, targeting a sitting systolic of 128 to 135 instead, and Harold's dizziness resolved completely within 3 weeks. The numbers looked less perfect. But Harold was steadier, more alert, and no longer a fall waiting to happen. This brings up something critically important that most seniors don't know. How your blood pressure is measured changes everything about what your doctor decides to do with it. Office blood pressure. The reading taken while you're sitting in an exam chair after walking through a busy waiting room and checking in at the front desk can be 10 to 20 points higher than your actual resting pressure. White coat hypertension, where the stress of the clinical environment artificially elevates your reading, is estimated to affect up to 30% of patients. That's nearly 1 in 3 people potentially being treated more aggressively than they need to be because a single reading in a stressful environment sets the entire treatment plan. On the other side, masked hypertension, where blood pressure appears normal in the office but is significantly elevated at home, particularly during daily activities, affects another substantial portion of older adults. A 2022 review in the Journal of the American Medical Association found that home blood pressure monitoring identifies clinically significant differences from office readings in roughly 1 out of every 5 patients. 1 in 5. That is not a rounding error. That is a meaningful percentage of seniors whose treatment plan could be fundamentally mismatched with their actual blood pressure reality. This next point could be the most important one in this entire video. Your diastolic number, the bottom number, deserves far more attention than it typically receives. Research from Johns Hopkins published in 2021 raised a significant concern. In adults over 65, diastolic pressure that consistently falls below 70 is associated with increased risk of heart attack, heart failure, and cognitive decline. The reason is straightforward physiology. Your heart muscle receives its own blood supply during the relaxation phase, when the heart fills between beats. If diastolic pressure drops too low, the coronary arteries, which fill during that relaxation phase, may not be getting adequate flow. you can be successfully chasing a perfect systolic number while slowly starving the heart of what it needs during every single beat. This is sometimes called the J curve phenomenon, the concept that both too high and too low carry increased risk, and the safest range sits in the middle of that curve. For diastolic pressure in older adults, most physicians now consider a target between 70 and 80 millimeters of mercury to be appropriate, with readings consistently below 65 warranting a careful review of your current medication regimen. Here's exactly what you should do with everything you've learned today. First, begin monitoring your blood pressure at home twice daily, once in the morning before taking any medications or eating breakfast, and once in the evening before dinner. Use a validated upper arm cuff monitor, not a wrist cuff. Wrist cuffs are significantly less accurate in older adults, particularly those with any circulatory stiffness. Before each reading, sit quietly for 5 full minutes. Do not talk during the measurement. Take 2 readings 2 minutes apart and record the average of both. Do this every day for 2 weeks and bring that complete log to your next appointment. 2 weeks of accurate home data is worth more clinically than 3 readings taken in a rushed exam room under stressful conditions. Second, know your personal target based on your age group. If you're between 60 and 79 and are not frail or managing advanced kidney disease, your systolic goal is below 130 and your diastolic should stay between 70 and 80. If you're 80 or older, discuss specifically with your physician whether a systolic target of 130 to 150 is appropriate, given your health status and how many medications you're currently taking. Third, ask your doctor to perform a standing blood pressure test at your next visit. Sit for 5 minutes, take a baseline reading, then stand up and take additional readings at the 1 minute and 3 minute marks. If your systolic drops more than 20 points, or your diastolic drops more than 10 points upon standing, you have orthostatic hypotension, and your medication plan may need adjustment before a fall occurs. Fourth, pay close attention to your diastolic reading. If it has fallen below 65 on a regular basis, bring this to your physician's attention directly. This is especially relevant if you're taking 2 or more blood pressure medications simultaneously. Do not adjust or stop your blood pressure medications on your own. Changes must always be made under physician supervision because stopping certain medications abruptly can cause dangerous rebound effects. But with your home monitoring log, your standing blood pressure test request, and your understanding of age-appropriate targets, you are now equipped to have a genuinely productive conversation, not a passive one, with your doctor about whether your current plan is right for who you actually are. And please, if you ever experience a severe sudden headache, vision changes, chest pain, or a reading above 180 over 120, that is a hypertensive emergency. Seek immediate care without delay. The one truth to carry with you from this video, there is no single blood pressure number that is ideal for every person over 60. The right target depends on your specific age within that range, your frailty status, your other health conditions, and critically, how your blood pressure behaves when you are upright and moving, not just sitting quietly in an exam room. The evidence is clear, and now so are you. Comment below with one of these. Type monitoring if you're already tracking your blood pressure at home. Type starting today if this video is motivating you to begin. Or type sharing this if you're going to send this to a parent, sibling, or friend who needs this information. Your comments help me know what content to create next, and they help every other senior watching this feel less alone in navigating this. If this video gives you something your doctor hasn't had time to explain, subscribe to this channel. I release new research-based videos every week built for people over 60 who want real answers. Next week, we're covering something that affects a significant portion of seniors silently. Why your blood pressure surges every single morning before you even get out of bed, and what you can do starting tonight to change that pattern. You will not want to miss it. I'm Dr. Sarah Mitchell. Take good care of yourself because you deserve to fully understand your own health.